So thanks a lot. This is a presentation which will probably be quite short, but it's on a quite an important subject and quite an important result for Eli Lilly. And this is
what that drug is.
Pardon?
Can you tell us what it is?
Yeah, it's a once weekly Tirzepatide versus once daily insulin degludec as an add-on to metformin with or without SGLT2 inhibitors in patients with type 2 diabetes. And it's a phase 3 study. So that's quite a long, it's obviously a very long title for a study, but essentially they're just comparing Tirzepatide, which is a co-agonist of GLP-1 and GIP. So there are two incretin hormones, GLP-1 and GIP, and that's a unimolecular co-agonist in Tirzepatide versus once daily insulin degludec when you're adding it on to patients who are on SGLT2 inhibitors and metformin. So it's a phase 3 study. So the background.
David, you want to tell people what GIP is? They might not be so familiar as GLP-1.
Yeah, so I've got a whole slide on it in a second.
Okay.
Oh, fine, sorry.
Just it's on the third slide, so I'll get to that just a second. So the background is to these anti-hyperglycemics. There's been a lot of progress in the last 15 years with newer classes of things such as the SGLT2s, newer GLP-1 monoagonists in the form of semaglutide, and obviously DPP-4 a while ago. But despite this, only 65.9% of people with type 2 diabetes achieved A1C of less than 7.5% in the national diabetes audit a few years ago. And that audit also showed that 85% of people with type 2 diabetes, unsurprisingly, were overweight or obese. And we know that obesity and overweight is a leading risk factor for type 2 diabetes. So there's been a real push from farmers to develop potent glucose-lowering agents with the added benefits of significant weight loss, and not like weight loss with SGLT2 or metformin. We're talking about filling a treatment gap, which is in the middle of lifestyle interventions and bariatric surgery, so up at about 15-20% weight loss. Some of this gap has been filled somewhat by things like Saxenda and liraglutide 3 milligrams and Ozempic off-label, but they're not really causing potent weight loss. So combining gut hormones in a unimolecular fashion, so in one molecule, offers the promise of both weight loss and glucose lowering actions. And Tirzepatide is one of these things that potentially could do this, because it's what's been called a twincretin. So it's a combination of two incretins, hence twincretin. So therefore, it's probably got going to have quite a potent effect on glucose control. But what does it do to body weight? And that's the question. And that's what was quite interesting out of this study. So GIP is glucose.
David, sorry to interrupt.
Yeah.
What GIP on its own is not very effective, is it?
No, exactly. I got that on a slide. And next,
okay.
But you're right. GIP on its own has been shown in type 2 diabetes really not to be very effective at all. But on the next slide, it kind of points towards a mechanism to explain that. But GIP is glucose-dependent insulinotropic peptide, and actually it was an incretin to be discovered prior to GLP-1 in the 70s. But a lot of focus was put on GLP-1 as a more potent incretin than GIP. It's a 42 amino acid peptide produced by the K cells, not the L cells like the GLP-1, and it's released in response to nutrient sensing. And the receptors, interestingly, are found in a variety of tissues, as you can see there. And from that table, you can see that this is where the kind of the summary action is. So mainly in the pancreas and the beta cell, it's an incretin, so therefore it stimulates glucose-stimulated insulin secretion, or potentiates that. And it also acts at the level of the adipose tissue. But other than that, there's not really any central action of this of GIP, like GLP-1, for example. As Waldit, you just mentioned, in type 2 diabetes, if you infuse or give GIP peripherally, it doesn't actually have much effect on glucose control itself. So there are unexplained mechanisms with GIP, and this was the slide that was potentially could point towards what's going on, but essentially we don't know, and the focus of this presentation is not really to get into the details of this, but essentially there are differences between GLP-1 and GIP. GIP is both glucagonotropic and glucagonostatic properties, so it potentiates glucagon release, and it also inhibits it at different levels of plasma glucose, which is quite interesting. For a long time, GIP was actually considered an obesity hormone because it enhances fat deposition, and if you antagonize it with antagonists to GIP, you actually have more weight loss in rodent models. So that's this is all preclinical data which suggests that actually it's an obesity hormone rather than an anti-obesity hormone. But there was a seminal study. There was a seminal study in 2016 in rodents, which actually gave the GIP GLP-1 combination in a unimolecular agonist, and it caused superior weight loss compared to GLP-1 alone. And that was quite surprising, because it was the first time that given a GIP has been shown to cause weight loss in rodent models. And it's been suggested that it could be because of biased agonism, that this is why GIP is having its effect. So the way that happens is at any certain receptor, there can be bias. So there might be downstream pathways which are differentially upregulated or downregulated. And it's thought that GIP may potentiate bias at the GLP-1 receptor and actually cause more signaling through downstream GLP-1 action. And so therefore, what GIP is doing by adding it to this Tirzepatide coagonist is actually potentiating the GLP-1 effect of Tirzepatide. It's all been discussed quite a lot in the literature, so it's definitely not been nailed down as to what the mechanism of this significant weight loss is with Tirzepatide. So in regards to the actual phase 3, this is all this is the Lilly drug development pipeline, which shows that you can see they've condensed all their phase 3 into the last couple of years, and they've ramped up the pace of this because obviously they're submitting all their approvals to the FDA and everywhere else. But Tirzepatide is, just to say, it's a long-acting peptide. It's got a fatty acid 20 carbon fatty acid chain, so therefore you only need to dose it once every 5 days. The study we're talking about today is SURPASS-3. So you can see there here SURPASS-3, and this comes after SURPASS-1, which is a monotherapy versus placebo trial, and these are all phase 3s, and then SURPASS-2, which is versus semaglutide, 1 milligram. And so today we're talking about SURPASS-3. And they've got studies going on at the moment looking at cardiovascular outcomes in SURPASS-5 as well. So this is a multi-center randomized, active controlled, open label parallel group phase 3. So essentially it means it's not a crossover trial. People were randomized 1-to-1 to 1-to-1 to the different groups, and they went through it concurrently and they weren't crossed over. It was active controlled, i.e. it's compared to degludec, so it's controlled with another active treatment. That's what that means. And it's a phase 3 over 2 years, 2019 to 2021. It's global. It was in many countries. They recruited about 1,700 participants, all 18 years and older, insulin naive with type 2 diabetes, uncontrolled, with an HbA1c of 7 to 10.5%. But they were all on metformin plus or minus SGLT2s. So some of them were on SGLT2s as well, and some of them weren't, but they were all on metformin monotherapy. And they were given either the degludec or the Tirzepatide at different doses. They were overweight with a BMI of at least 25, and they were randomized to the Tirzepatide once weekly 5, 10, or 15, or once daily degludec. And at randomization, the groups were stratified for things like the baseline HbA1c and whether they were on an SGLT2 inhibitor in addition to the metformin. So they had equal numbers of people in each group with similar levels of A1C and similar numbers of people on the SGLT2s as well as the metformin. Open label, i.e. wasn't blinded because the participants had to give themselves the pens. It was just too tricky to blind it. So this is the study plan, the study protocol. So there was a screening for at least a week, and then there was a lead-in for 2 weeks. And that lead-in time basically is post-randomization. It gives them the opportunity to exclude if anything crops up during that time. And it's just to ensure stability in the patient. And then they were started on the groups. You can see there 5, 10, 15, and they were dose incremented on Tirzepatide by 2.5 milligrams once every 4 weeks until they get to their target dose of 5, 10, or 15. The insulin degludec was titrated to effect to a fasting glucose of less than 5. And they had a specific algorithm to do that. The study was over 52 weeks, and then there was the endpoint at 52 weeks. And really, a lot of their outcomes are just comparing baseline to 52-week outcomes. This was the titration, the insulin degludec titration protocol. So it was based on a median of three pre-breakfast SMBGs, or self-monitored blood glucose values, and the aim was to get to less than 5. So if the participants had any GI side effects, which is the most likely anticipated side effect, they would be dose escalated and continued on a lower dose for the remainder of the study. There was an intention to treat study, so therefore they would be analysed as if they were allocated to that original treatment group. There was the option of initiating new anti-hypoglycemics during the study only for rescue therapy for persistent hypoglycemia. And the primary outcome was A1C at 52 weeks to determine non-inferiority of the higher doses of Tirzepatide versus degludec. There were lots of secondary outcomes, which we can show in the results. And there was exploratory outcomes and obviously safety endpoints. The design, basically was powered to show non-inferiority, and if they had superiority, that's a bonus. Then they had two different. They report in their paper they have two different estimands of treatment efficacy: the efficacy estimand and the treatment estimand. But basically, that one of them just includes all the people who had rescue anti-hypoglycemics. But I think for the point of this is that just confuses things, and they just looked at the efficacy estimand. So everyone who didn't receive any rescue anti-hypoglycemics were shown in the results. It was a modified intention to treat analysis. I'm not sure what the modified means, but it's I think different people interpret that differently. The Lilly were the people who funded it. They analysed the data, they wrote the reports, etc. So all in all, there was 1,947 participants, 1,444 randomly assigned, and you can see there's pretty much equal split in patient number across the groups. And there was a small dropout rate for each of the groups. In terms of the baseline demographics, really everything, because of that stratification system at randomization, everything was quite equal with regards to A1C. But you can see there was a pretty much an equal split, male, female. It was mostly white in terms of demographics and races. It was a white population. The A1C at baseline was high, but obviously it was stratified at randomization, so therefore it was around 8.21 or something like that across all groups. And again, stratification for the SGLT2s, so around 70% of participants in every group were on metformin alone, and then about 30% were also on the SGLT2 inhibitor. BMI was pretty well split, and EGFR and urine ACR as well. So these were the main results in a table, and I know it's very small. I hope you can see it. You may not be able to see it, because it's so small.
It's too small. Can you tell us what
I'll tell you, there's some graphs in the next slide which also sum this up, but essentially their headline data is that the HbA1c dropped quite dramatically in the highest tirzepatide group. So the degludec group, the participants there experienced an A1c reduction of 1.34% over 52 weeks, compared to the highest dose of tirzepatide at minus 2.37. So that's a minus 2.37% reduction in HbA1c over 52 weeks, compared to the lowest dose of tirzepatide, which was minus 1.93. So even the lowest dose of tirzepatide was higher than and actually superior than insulin degludec. There was a dose dependent. There was a dose dependency in the amount of participants who reached A1Cs of less than 7, 6.5, and 5.7% as you went up the dose of tirzepatide compared to degludec. So, for example, 48% of people in that highest tirzepatide group reached a HbA1c of less than 5.7, which is quite staggering, really. The fasting glucose levels were quite similar between all groups, including degludec and a tirzepatide group. And interestingly, an analysis of 7-point SMBGs, these self-monitored blood glucose levels, where you measure your blood glucose throughout the day, pre-post meal, and fasting, an analysis of that showed that actually it was the 2-hour post-meal glucose which seemed to have there was the biggest effect in that parameter. So the 2-hour post-meal glucose rather than the fasting glucose in the tirzepatide versus degludec group. And perhaps that's not unsurprising, since this is a twincretin or two incretins together. Just to say, there was no differences in subgroup analysis for HbA1c between those on metformin alone or metformin plus SGLT2 who were given either degludec or the tirzepatide. So no real difference there. And that's probably not unsurprising, since neither SGLT2 or metformin have such a dramatic effect on HbA1c as tirzepatide does. Body weight. So this was an interesting finding that perhaps was expected based on that preclinical study by Finan in 2013, but there was a significant reduction in body weight at 52 weeks. Tirzepatide, a 15 milligram dose, reached a body weight loss of 12.9 kilograms over 52 weeks. So that really is, filling that treatment gap of obesity pharmacotherapeutics right there, and compared to
15 milligrams.
15 milligrams a week, yeah.
And what did the insulin do to body weight?
It added body weight by 2.3 kilograms. So the ETD, the treatment difference between the two is 15.2 kilograms.
So with insulin, you put on weight, even degludec, and with tirzepatide, whatever it's called, you definitely lose quite a lot.
Yes, exactly. So you lose a lot of you reduce your HbA1c a lot, and you're also losing quite a significant amount of body weight as well. And even at the lowest dose of tirzepatide, 5 milligrams once a week, they lost 7.5 kilograms of body weight, and that was a 9.8 kilogram difference to the degludec.
So just go back to the last slide to the A1Cs for a second, just so I can. So just point to the A1Cs for me so I can see. Okay, so minus 2.37
versus that.
Yeah, so you have a better A1C and you lose weight.
Yes.
Okay.
Yes, and their cutoff to show non-inferiority, well, they actually were setting out to just show non-inferiority, was based on an efficacy of 0.3% change in A1C. And actually, you can see with the confidence intervals here of minus 1.17 to minus 0.9, you've got minus 0.9 as your upper confidence interval here. So you've not only shown non-inferiority, you've shown significant superiority.
Yeah.
3 times their cutoff for it. Anyway, so what was quite they have these composite outcomes, and this is quite important because actually they want to show that you can achieve this without causing hypoglycemia, because that's really important, because the main question you would ask is, if you're achieving HbA1c less than 5.7 in such a large proportion of participants on 15 milligrams of tirzepatide, well, are they all going hypoglycemic at certain points? and actually they showed that no, they're not. So this composite endpoint here is their composite endpoint is a HbA1c target of less than 7 without weight gain and without clinically significant documented symptomatic hypoglycemia or severe hypoglycemia. And 91% of participants in that highest dose tirzepatide met that outcome, which is good. You don't want hypoglycemia, and also it fits with the physiology of an incretin, because this is glucose potentiated insulin secretion. So therefore, you wouldn't expect hypoglycemia.
Outcome particularly tied up to insulin, doesn't it? Because insulin, of course, causes hypoglycemia. So I can see only 15% of the insulin group achieved that outcome.
Yes, exactly. You'll see it on the there's another table where basically, you'll see that reflected in another table, and they experience more hypoglycemic events. So this is in graphs. Is that too small? I hope you can see that.
It's small. If you point it out, that'll be fine.
Sorry, I took these pictures and just put them in, but maybe I should have taken them individually. But essentially, the HbA1c reduction here at 52 weeks is pretty comparable between all doses. It's obviously best at the highest dose, but it's comparable there. It's just showing the HbA1c reduction in graph A. In graph B, you can see again body weight loss is still good at 5 milligrams a week of this drug.
Okay, just so everyone knows, right? So the blue ones are obviously the drug, and red is insulin degludec.
Red is insulin degludec, yeah. And so really it smashes past the insulin degludec in A1C and from baseline. This is all A1C, this graph actually, it's all glucose. Participants reaching, in C, it's participants reaching those targets as less than 7%, less than 6.5%, and less than 5.7%. Again, you can see all the doses tirzepatide, significantly reach that. Fasting glucose in D doesn't seem to change, and that fits with our understanding of this drug and these hormones. And again, fasting change is in E as well. There's no significant change. But what you can see in F is quite an interesting graph. It's the plot of the SMBGs, the 7-point SMBGs. So throughout the day, you can see there the baseline is in dotted at the top, and the 52-week analysis of it is in the bottom in solid lines. And you can see there all groups achieve better glycemic control. But for the SMBGs, the fasting was the same. But as you go throughout the day on this up and down curve, throughout the day, there's a divergence, and the divergence occurs post meals. So you can see that tirzepatide there, all those 3 doses, is keeping your post-meal glucose down.
Yeah.
And potentially that's why it's adding to this HbA1c result, and this is what's explaining it. That's quite an interesting graph. Body weight, this is all body weight. Again, you can see big reduction in body weight there across the 3 groups. The highest dose seems to have certainly a more potent effect on body weight than compared to the lowest dose than it does for your glucose control. So with the glucose control, you seem to get pretty comparable to the higher dose at the lower dose, but for body weight, you really do need to be giving this higher dose to pushing up to 12 kilograms weight loss. Waist circumference reduced, and BMI reduced, and lipids improved as well. So the lipid profile improved, in particular the HDL cholesterol increased compared to degludec, and the VLDL level and the LDL levels also reduced with dose dependently. And that may be, that may be related to we don't know the mechanism. That could be related to the actual weight loss per se, or it could be related to the action of GIP on adipose tissue, because we know it's got receptors in the adipose tissue. So we don't know. Cardiovascular results. So there were changes in pulse rate, blood pressure, and diastolic blood pressure. So the pulse rate increased. This is consistent with GLP-1. This happens with GLP-1. There's an increase in pulse rate, which is transient and then comes down again. And I don't know what the cause of that is. There's a reduction in systolic blood pressure and diastolic blood pressure, and that's quite significant over time, although it looks like really small changes, but this had such high numbers of participants in this study. It's a significant reduction, 6 millimole per mercury reduction in systolic blood pressure over 52 weeks. That could be multifaceted, that mechanism, to do with reduced body weight. As body weight is, there's a number of mechanisms by which body weight increases blood pressure.
Tachycardia is not a good thing, I don't think, but
Sorry, say again, Kieran?
the pulse rate going up is a bit worrying, because that's not a marker of health at all.
Oh, yeah.
Doesn't matter. Well,
Because we know that they have a better mortality in GLP-1.
yeah, true. Okay.
So side effects. So this is the table you were alluding to, Karim, in the previous slide. You can see the hypoglycemic events there. If you look at other adverts here and hypos, hypoglycemia, 48% of individuals on Diglidec experience hypoglycemia. They define it as less than 70 milligram per deciliter, which is about 3.9 millimole per liter. The 54 milligram per deciliter is about 3 millimole per liter. So 48% of people were going under 3.9 at various times. And in terms of the main, as you can see, the hypoglycemic events for the tirzepatide at the highest dose is quite important to mention. And actually 14% of participants at that highest dose experienced a glucose less than 3.9.
But mostly above 3, because
Yeah. And interestingly, you can see with the hypos, there was one severe hypo in the tirzepatide 15 milligram group. And when you read into their results, they actually experienced that when they were on the dose escalation at 2.5 milligrams, but they got to 15 milligrams, and they continued 15 milligrams for the rest of the study, but they had the severe hypo on 2.5. So it was a bit odd. But yeah, clearly there's no major issues with severe hypos with the tirzepatide. But yeah, it performs better with regards to hypoglycemia. And in terms of the main adverse effects, I mean, of course, very sadly, 5 participants died during the study, and it wasn't a result of it's kind of independently adjudicated by independent panel of people to investigate this, of course, but it wasn't related to the tirzepatide dosing, and the reasons are on the right of the screen that you can see. So it's a variety of reasons. The adverse events that they're really focused on is the nausea and the vomiting, because this is the main adverse effects of GLP-1. And you can see there that there was a dose-dependent increase in the nausea and the vomiting. And I think if you look under the TEAEs, the treatment emergent adverse events part here, you can see that at the highest dose, 24% of participants had experienced nausea, compared to 2% with the Degludec group. And at the lowest dose of tirzepatide, 12% experienced nausea. So there was a dose-dependent increase in nausea, and this is in keeping with other GLP-1s like semaglutide and liraglutide. This is kind of the same figures if you give a high-dose GLP-1. But importantly, the nausea is short-lived, so it's transient. And the biggest effect is actually in the first few weeks, and then it dies down again. And you can see there at 52 weeks, pretty much the nausea score or percentage of people with nausea is very low on the dose of tirzepatide, 50 milligrams. So in conclusion, these are very translatable results. And I think this phase 3 is really designed to say, look, if you've got your patient on metformin and SGLT2 with poor glycemic control, what are you going to add on? And based on this, you would add on tirzepatide. And because it shows obviously, it shows obviously superior weight loss as well with minimal hypoglycemia. And for this reason, it's currently being probably approved by the FDA. All 3 doses lead to superior changes in A1C. At the highest dose of tirzepatide, 93% HbA1c of less than 7% at 52 weeks. The greatest effects was on postprandial glucose, as we saw, not the fasting glucose. The body weight reduction up to 12.7 kilograms is quite impressive, and it's around 15% based on their baseline body weight. And this is comparable with the their dose of tirzepatide in the SURPASS-2 trial, which was comparing tirzepatide with semaglutide 1 milligram. And semaglutide 1 milligram achieves a weight loss of 5.7 kilograms and an A1C reduction of 1.86%. So you can see immediately the differences in tirzepatide versus semaglutide 1 milligram. However, the field is moving very quickly, and semaglutide has been has been researched or trialed in a phase 3 at 2.4 milligrams subcutaneously weekly, with 15.3 kilograms weight loss over 68 weeks. So that's quite comparable to tirzepatide. However, the HbA1c loss with that is around 0.4%. So you can see that tirzepatide's got basically a double action on potent weight loss and glycemic control compared to semaglutide. There's an improved lipid profile with tirzepatide, and we don't know exactly why. It's probably multifaceted. There's other studies going to look at cardiovascular risk and also effects on liver enzymes, because they actually improved. The liver enzymes improved in this study. I didn't show that data, but they did improve. So therefore, it's been investigated in view of hepatic steatosis treatment. And the AEs are dose dependent. So really, the gut hormone-based multi-agonists are showing real promise in addressing weight loss and glycemic control and minimizing side effects by combining the two. And really, this is, I think, a race between Lilly and Novo, because obviously they've got their two competing drugs, the semaglutide and the tirzepatide. But it's likely that the tirzepatide will become the first licensed co-agonist for the treatment of obesity and type 2 diabetes, which is quite exciting.
Yeah.
And that's the end. And just, this is
Thank you.
reference. But yeah, so.
David, any data on calcitonin and MTC?
Yeah, there was data on calcitonin. It was in their results. There was no significant change in calcitonin. Sorry, I don't have the exact numbers, but it's certainly they did report it.
So in about 2 years from now, we'll have Alex coming along saying we need to pay for this.
12 months.
In 12 months, you reckon?
Yeah, it's planned for 12 months for diabetes.
Yeah. They'll have all this.
Is there not only so kind of cardiovascular outcomes now from last year as opposed to improvement in HbA1c?
I think they've done.
They're doing that SURPASS-5, he said, yeah?
I think the SURPASS-5. Yeah, so that might be one. They're either doing it or they're planning it. I don't know which one is superiority and which one is superiority.
Right.
But they're planning for autumn next year.
Okay, so it's going to be a cost pressure, David. That's the thing.
I mean, this is going to bankrupt the NHS if it's proven to be safe long term, because it's brilliant. I mean, it's unbelievable, isn't it? It does everything that you'd want, 20 years ago in terms of weight reduction. It's a miracle, but we probably can't afford it.
Yeah. Yeah, I mean the lipid drug has just been widely touted as going to be given to lots of people. There's a deal with the NHS to kind of make it available at some level, but it'll still be a cost pressure. But yeah. That's what they need to do, don't they? They need to get some sort of agreement with the company in advance, which I think some of them have done.
Saxenda.
Oh, Saxenda has done, have they? Oh, I see. Okay.
So all the GLP-1s now priced at the same. It's about 78 pounds a month. That's kind of fixed.
Yeah.
How much of that compared to incentives for those doing it?
Well, it depends on the issue as well.
Look at that. That's like more expensive.
Definitely it's expensive.
Yeah.
But if you use assembly, then it's not cheap. So then it's more expensive like glucose.
My favorite drug. Okay. Thank you, David. That was really clear.
Thank you, David.
But, hang on. There's a raised hand up there. I just saw someone. Layla.
Yeah, hi David, thank you. That was excellent. I just wanted to ask your opinion on. So, do you think the glucose lowering effect, the significant glucose lowering effect, is down to GIP, given that all the other GLP-1 agonists on the market haven't achieved such such great results in that area?
Yeah, it's a good question. I mean, we don't know the exact mechanism, but the SMBGs point to obviously the post meal reduction. So it seems to be an incretin effect, and it could be that it could come back to the bias mechanism. So adding GIP actually favorably biases GLP-1 signaling, because we know that post GLP-1 receptor, and Ben Jones is an expert in this area and doing research into this at the moment. You have beta-arrestin recruitment, which can affect how long the GLP-1 receptor is at the membrane and being stimulated. So it could be as a result of bias at the receptor. So really what we're doing is it's a kind of a supercharged GLP-1 agonist because of the GIP. But
Okay.
we that's just a sort of a hypothesis. We don't actually know the exact mechanism. So yeah.
Cool, interesting, thank you.
Any other thoughts, questions? Anyway, so yeah, so you think it's a
David, there was a JCI paper recently on mechanism from, I think from Lilly, about what it might be doing to white adipose tissue and things. And there's various grants that I've kind of sat in on and reviewed that are looking at the mechanism.
right.
But it does look like there's some magic of
Yeah.
the GIP being added at the beta cell in addition to the weight loss effects on insulin.
Yeah, exactly. And I don't know whether that bias is occurring centrally as well. I mean, that may explain it. It would be interesting to do food intake studies and look at that as well to see how much of this effect on weight loss is peripheral in the adipose tissue and how much is central through food intake reduction.